All right, thank you for joining us for the Kirby Institute seminar series. My name is Lucette Cysique, and I'm an associate professor and a senior research fellow here in the VIS program. And I would like first to begin by acknowledging the traditional custodian of the lands on which we gather today and pay my respect to their elders past and present. Today we are presenting from Bidjigal people of the Eora Nation. I extend that respect to Aboriginal and Torres Strait Islander people joining us today here in the audience and online. Some housekeeping to start off with. The format of the seminar will start off with a presentation followed by a Q&A session after. So we have all the presentations and then the Q&A session. If you are joining us online today, you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. For our audience in the room today, a microphone is available to the side of the room to address your question at the start of the Q&A session at the end of the presentation. All right, so I'm going to introduce our first presenter. So Professor Nick Medland is a sexual health and HIV physician, immediate past president of ASHM, and chairs the Australian STI management guidelines. He has been at the Kirby Institute since 2018. And his area of research is the population control of HIV and sexually transmitted infection through clinical interventions, including HIV treatment as prevention and pre-exposure prophylaxis and STI testing and treatment. He has more than 25 years of clinical experience, including in a community setting. For 6 years, he worked in senior roles in the US government funding HIV program in Vietnam.
So my presentation is the incidence of HIV in users of HIV pre-exposure prophylaxis in Australia, a whole of population analysis. And I presented this about a month ago at CROI in Denver. And thank you for the opportunity to presenting this to the Kirby today. Of course, first I'd like to start by acknowledging the traditional owners of the lands that we're meeting on today, the Bidjigal people, and acknowledging the traditional owners of the country throughout Australia and the Aboriginal Torres Strait Islander people's continuing connection to culture, land, sea, waters, and community, and pay respects to elders both past and present. So Australia has had a highly accessible and successful government subsidised PrEP program since April 2018. It's been almost exclusively targeted at gay bisexual men. We have more than 70,000 initiations in a population of 25 million. And as this was presented in America, by population, this would be about 1 million Americans on PrEP. Any doctor can prescribe PrEP in Australia with a very low patient payment. However, to achieve elimination of HIV transmission, we need to know how effective is PrEP when it's scaled up over the long term. How do you measure incidence outside of studies and what the comparators would be? Australia has a quite fractured, I guess, or a quite fragmented healthcare system. However, there are some unique factors that allow a new whole of population analysis using prescription data. Firstly, we think about 90% of people taking PrEP in Australia are accessing it through this government subsidised program. Longitudinally, over the course of people's entire access to PrEP, it's probably higher. There are very high rates of testing for HIV in gay and bisexual men who use PrEP, with more than 99% of people who say that they are currently using PrEP having used it in the last year. And also, we have rapid uptake of antiretroviral therapy using the same pharmaceutical benefits scheme, with more than 95% initiating within 6 weeks, where it's been measured in New South Wales, and overall 98% who receive a new diagnosis on ART. So the aim of this study was to use linked, de-identified government prescription dispensing data for PrEP and ART to estimate HIV incidence among people who've received PrEP in the 5 years from April 2018 to March 2023, to look at predictors of HIV acquisition and make an estimate of the overall population effectiveness of PrEP using those who only received PrEP once as a comparator. So we're able to look at de-identified linked prescriptions from PrEP, ART, and hepatitis C up to the end of the study period, plus an additional 6 months observation period up to September 2023. And these are some of the data that appeared on every prescription. Very small amounts of information about a lot of people and linkage codes. Now, these are 3 very substantial assumptions that allowed us to take these prescribing data and estimate incidence on the basis of them. Firstly, we assumed that people who'd received PrEP were tested for HIV twice a year or when PrEP is prescribed. So we had no direct testing data available. And this is because of the known high rates of testing in PrEP users. And similarly, we assumed that people had not initiated PrEP in the 6 months not initiated ART in the 6-month period after the end of the study period, that then they were HIV negative at the end of the 5-year study period. ART initiation was a proxy for receiving an HIV diagnosis because of the known rapid initiation after diagnosis. And we imputed the date of HIV acquisition as the midpoint between 30 days before ART initiation and the most recent PrEP prescription, or 6 months earlier. So looking at this visually, this person here had never initiated ART and was assumed to have been HIV negative at the end of the study period. This person did initiate ART, and we imputed the date of acquisition as the midpoint of 6 months between 30 days before the first ART presentation, first ART prescription, 6 months before that point. And this person had a more recent PrEP prescription, so we imputed the date of HIV acquisition as between 30 days before the first ART prescription and the last PrEP prescription. We used the date and quantity supplied to calculate the days covered by PrEP between the first prescription and the end of the study period, or the imputed date of acquisition. And we categorized them into 3 groups. A very low exposure category. These are people who were dispensed PrEP once only and never came back for second prescription, and a high exposure category with more than 60% of days covered by PrEP, and then everybody in the middle. We were able to look at postcodes and categorize them according to a published estimate of the prevalence of gay men in that postal district, and we're able to estimate the PrEP caseload as the number of individuals that each particular patient's doctor had prescribed PrEP to. We did several sensitivity analyses. This is just the overall study population. There were more than 66,000 people included. 2.2% were women, and out of that 66,000, 207 acquired HIV during the study period. The follow-up period was 39 months. There was about 430 days median between the last PrEP and the first ART prescription. So that's the first thing I'd point out, that most of these people had been off PrEP for quite a period of time. Out of the 19% of PrEP users who received PrEP only once, that's quite a lot, they represented 30% of HIV acquisition. And the 27.5% of PrEP users who had more than 60% of days covered by PrEP represented 15% of HIV acquisition. Now, these are the numbers over here on the left, but we can actually look at these bars over here, and these are incidence rates per 1,000 person years. So the overall incidence rate was 1.07 per 1,000 person years. That's very low. The first thing that jumps out, amongst people who'd received Hep C treatment during the study period, there was almost a 10-time increase in incidence. I'm just going to give this a little bit of a stretch, and you can see that there is an age range with the younger people having the higher incidence rates. The main difference you'll see here is that those with a single PrEP supply had the next highest incidence rate, which was 2.61, and those with the most numbers of days covered had the lowest rate. Looking at adjusted incident rate ratios, the things that came out as statistically significant were age less than 30, having received Hep C treatment, having a single supply, having less than 60% of days covered, and also year of PrEP initiation. This is the Kaplan-Meier curve showing the three PrEP exposure groups, and you can see the high exposure group with the lower incidence rate eventually separating here, and the low exposure group separating right early on. Now, if we use people who receive PrEP only once as a comparator, and these are people who are considered at some point to be PrEP eligible and whose ongoing risk was contemporaneous with their peers in the study, having more than 60% of days covered reduced HIV incidence by 79%. And having less than 60% of days covered reduced HIV incidence by 62%. So the strengths of this study, there was a high degree of completeness for the whole country. The weaknesses, it was prescription data only. All the rest is inferred. However, we produced several sub-analyses and sensitivity analyses and shows almost identical results. There are limited covariates. There's nothing on behaviour. We can't distinguish cis and trans men and women in this study. We have nothing about race or ethnicity. And it doesn't include the large temporary visa community with known HIV intersectionality and who are not eligible for this program. So in conclusions, this is a nice low overall incidence rate, which is good news for expanding PrEP programs over a very extended period of time. The population effectiveness for ongoing PrEP use is high. Where we can do better is starting to emerge in those groups who don't come back from multiple prescriptions. There's a high incidence of people who received Hep C treatment, which likely represents an intersectionality of risk given the low rates of injection transmission of HIV in Australia. And I wonder whether or not we need to, at least some individuals, think about a longitudinal model of preventive care. Those with lower consumption consist of a mixture of people at low or no risk and those who are not correctly matching risk for PrEP use and identifying those for extra support. Young people, those who don't come back for refills, those with HCV risk factors might benefit for additional support and being identified up front. People who live and see doctors outside of inner urban gay areas, while not statistically significant in this study, might be identifiable as needing more support. Thank you very much. I'd like to acknowledge my co-authors, the Australian government that provide these data, and those people who've received PrEP subsidised by the Australian government. Thank you very much.
And I'm going to introduce you is Dr. Joanne Carson. Dr. Joanne Carson is a cross-disciplinary infectious disease and data science researcher at the Therapeutic Vaccine Research Program and Virus Hepatitis Clinical Research Program here at the Kirby.
Before I begin, I would like to acknowledge the Bidjigal people of the Eora Nation and pay my respects to elders past and present. So it is an absolute pleasure to be on these beautiful lands today to present findings of the CEASE study, which assessed Australia's progress towards elimination of HCV among people with HIV. So in 2015, there were an estimated 2,000 to 2,500 people who were living with HIV and hepatitis C co-infection in Australia. In 2016, a global effort to eliminate hepatitis C by 2030 commenced when highly effective direct-acting antiviral treatments became available. So the World Health Organization HCV elimination targets to reduce the prevalence of HCV by 90%, to reduce the incidence or new infections by 90%, and to reduce HCV-related mortality by 65%. So people with HIV and HCV co-infection are at increased risk of liver disease progression, and because of this, this population was prioritized for treatment as soon as DAAs became available. So the CEASE study assessed the impact of rapid DAA scale-up among people with HIV and HCV and our progress towards elimination in this population. So CEASE was a prospective cohort that enrolled people with HIV and HCV antibodies, irrespective of HCV RNA status, so whether they had current infection or were previously exposed. There were 3 study visits enrollment that ran from 2014 to 2016, follow-up 1 from 2017 to 2018. And then after some COVID-related delays, we finally had our last follow-up 2 in 2021 to 2023. So at each of these study visits, we collected biobehavioral data, so blood samples, liver fibrosis measures, and behavioral data. And we also collected clinical data from medical records, so HIV-HCV testing, and this was extracted for at the visit and for during the periods between study visits. So looking at our population characteristics, so we had 402 participants, 12 primary care sites and 2 tertiary sites. Sites were in New South Wales, Queensland, South Australia, and Victoria. So the population was predominantly male with a median age of 49 years. 84% were HCV RNA positive, so they had current HCV infection. 13% had liver cirrhosis. 82% had a history of injecting drug use, with just over a third injecting in the past 6 months, and it was predominantly stimulant injecting in this population. So 83% identified as a gay or bisexual men, and of this population, half reported condomless anal intercourse with casual male partners in the past 6 months, and a third reported group sex. And these behaviours remained relatively stable over the study period. Okay, so this chart seems to confuse everyone, so I'm going to do my best to explain it as simply as I can. So this is an alluvial plot of HCV status and states over the study period. So what I'm tracking is the way people transitioned between being HCV RNA positive, which is there in that dark blue purple, HCV RNA negative in the light blue purple. Then in the blue, we've got death, and then in the green, lost to follow-up. Although I do want to emphasize these people, most of them weren't lost to follow-up. They simply moved interstate or to another country, and their results weren't available. So what really stands out from this figure is the dramatic shift when DAAs became available in the proportion of people that were HCV RNA positive. We can also see where people, both those purple lines, are going from being sort of HCV RNA negative, becoming reinfected, being retreated. So if you look at it, it's quite an informative figure, but I realize it's a little bit much at first. So by the end of the study, 91% of our population who were HCV RNA positive had been treated, 2% spontaneously cleared, and for 7% we didn't have results. So the HCV RNA prevalence declined in this population from 84% at enrollment, it was 8% at follow-up 1, all the way down to less than 1% at follow-up 2. So at follow-up 2, there were 2 participants that were HCV RNA positive. So one of them had primary infection. This individual was Medicare ineligible. So he was unable to access treatments through our government subsidised scheme. So instead of paying $30, he would have to pay up to $30,000. At this time, he was given compassionate access through a pharmaceutical company, and he did achieve cure before the study ended. The second individual, he was successfully treated twice and reinfected twice. So he was quite a chaotic chap and in and out of prison. And it's quite likely that his exposure, particularly in the later stages of the study, was due to his incarceration. So how was this rapid DAA scale-up achieved? But I don't think any other country in the world has been able to do this except for Australia and potentially Iceland, that has a very small population. So first of all, we had a national HCV strategy that prioritized DAAs for people with HIV and hepatitis C. We had community advocacy and engagement. People with HIV generally have high rates of linkage to care. They also have high rates of BBV and STI screening. So this meant that most HCV cases in this population were diagnosed. HCV treatment expansion didn't only occur in tertiary care, it was expanded in primary care. And I do want to emphasize that there was a real focus on patient-centered care. So a lot of these patients were incredibly complex. So achieving cure was a challenge for one individual. It took 4 rounds of treatment. So he had sort of methamphetamine dependence, and he discontinued treatment 3 times. And then on the 4th round, he achieved HCV cure. And he was so thrilled on the 4th round that he actually sent a message through the study saying, thank you, and being in CEASE had changed his life. So our study PI, Gail, who's a tertiary doctor, went to primary care and retreated him, then retreated him and worked with him again until he achieved cure. So showing kindness to a vulnerable population and just not giving up on them, I think, can really make a difference in someone's life. Finally, we did have a relatively small population with HIV-HCV. So it was probably less than 10% of the total population with HIV. In comparison, our population of people who inject drugs who are also impacted by hepatitis C is much larger, and the prevalence at this time was around 50-something%. Next, looking at reinfection incidence and risk. So this reinfection incidence is a really good indicator of what's going on in incidence in general. So most recent studies are showing that primary incidence and reinfection incidence are generally very similar. So the reinfection incidence in this study was 1.8 per 100 person years, and you can see the cumulative hazard figure at the top there. Most of the reinfections that occurred were pretty shortly after treatment. The figure below is a generalized additive model estimating the longitudinal risk of reinfection. So as the prevalence has declined, the risk of reinfection in this population has also declined. So the factors that increased reinfection risk in the overall population were opioid injecting, and among gay and bisexual men was group sex. Now looking at death incidence and risk. So our death incidence exceeded our reinfection incidence at 2.3 per 100 person years, and this remains stable over time. So the median age at death was 56 years. The factors associated with death were increasing age, liver cirrhosis, and a history of opioid injecting. So the top figure is displaying the survival probability of people with and without cirrhosis. And then the one below, people with and without a history of opioid injecting. And I did want to note that collinear with opioid injecting was younger age of first injecting drug use initiation and lower education. So in general, this group were quite socially and socioeconomically disadvantaged. The single most common cause of death in this population was sepsis, but that only accounted for 17% of the 30 deaths. Underlying cirrhosis was present in 1/3, and there were 3 liver-related deaths, so 1 hepatocellular carcinoma, 1 cholangiocarcinoma, and 1 hepatic decompensation or liver failure. But what was apparent in most of these deaths was that there were complex chronic conditions, both mental health and physical health. Yes, in summary, DAA treatment was scaled up rapidly among people with HIV and HCV. The HC prevalence declined from 84% to less than 1%. And HCV reinfection incidence and risk declined, while death incidence remained stable. So the rapid scale up of treatment has had a treatment as prevention effect in this population. So HCV prevalence and incidence elimination targets may have already been achieved in Australia among people with HIV. However, HCV surveillance for people with HIV and HCV risk behaviours should still be continued. This is a largely susceptible population, and if they do have risk behaviours, this surveillance should certainly continue even though the risk has decreased substantially. Finally, we do need to do further research to assess our progress towards mortality targets and how we can improve post-HCV health outcomes for this population. There were so many people involved in the CEASE study over its 8 or 9 years of existence, and I actually came on board fairly late in the game, so around 2018, 2019. So I'm going to, first of all, thank the study participants who generously donated their time to our research. Without them, this would not have been possible at all. From the Kirby Institute, Gail Matthews, a CPI, and Marianne Martinello, who's an infectious disease physician and academic on this. So they've been with the study from start to finish, and they've really been the ones that have driven this through. Ekaterina Philipp, who is no longer with us anymore, she's in France, but she also worked on the study from start to finish and did an incredible job managing very complex data sets. Our study partners and our site investigators and coordinators. I didn't have room to list the coordinators, but they did an amazing job of getting the patients in and conducting all the study visits. And finally, I would like to leave you with some images from the Rocky Mountain National Park in Colorado, which is about an hour and a half outside of Denver, where the CROI conference was. So thank you.
Well, the next presentation is myself. So I'm going to give some of the highlights of the what we call NeuroHIV studies at CROI. So it's basically not really my research, but a lot of it is other people's research. But I think some of it will be of interest to this audience in terms of how there's an increasing recognition that we need to look at the brain. So the first thing I thought was relevant to the Kirby Institute was the evidence that there is I mean, I think you know that, but I just want to emphasize that it was the topic of invited presentation at CROI, with continued rise of syphilis and neurosyphilis. There was 3 sessions on improving diagnosis management, including congenital diseases. So some in the US and from Brazil. So it's just kind of a note that you can look in the abstract book about those sessions. The next one was what I call theme 1, was about persistence of HIV in the central nervous system. CNS stands for central nervous system. There was an invited talk by Sharon Lewin from the Doherty. And basically she presented about the importance of considering the CNS in terms of consideration for cure strategies. So according to her talk, she stated that numerous studies have now clearly demonstrated the persistence of intact and transcriptionally active HIV in the CNS. Although the frequency of the cell infected is small, we know that's not an issue for replication having an impact on the brain. So I think what was interesting is that she actually used some of the data about latency reversing agent and where they shown some specific impact on the brain, so more on astrocytes than monocytes derived macrophages, which is an important consideration because eventually the main cell in the brain is not targeted. Astrocytes don't have that much infection. Then the next thing she mentioned is the importance for those treatment to be able to cross the blood-brain barrier. And there's been some clinical trials showing that they're not only able to do that, but most of the outcome are actually not negative without significant adverse event. And that's important because that's one of the things that we worry about in NeuroHIV, is that some of the treatment are going to result in severe encephalitis. And so she said that's not the case except for one particular combination. The next thing is that, I don't know how much of you are aware, but probably some of you are more aware than I am, certainly, that NeuroHIV specific agent for latency reversal agent are being tested right now in animal models, but that those models need to be assessed for neurotoxicity. And then she presented evidence in immunotherapy, gene therapy, and basically the knowledge is to be considered there. We don't know what's is going to happen. And then another things that may perhaps optimistic for us in the NeuroHIV field is that, one, if people have to stop treatment like they have to for initiation of potential cure therapy, that the immediate outcome is not catastrophic for the brain, except in a minority. The next slide, it was also about the persistence of the CNS, and it's the Melissa Churchill group in Melbourne. She basically had presented earlier in the year in Archive of Neurology evidence that HIV DNA in the brain was present in 66% of people who were virally suppressed. There was a sample of 9 people, so that's always something to keep in mind. But the presentation at CROI was about the level of transcripts, so it was an extension of a current work on this. And what she shows, she shows that in the frontal cortex tissues, there is evidence of continued transcriptional initiation in all of the individual tested, independently of whether they were virally suppressed or not, and that there was evidence for early elongation in 92%. On the top of that, she shows that completion of transcription and multiple splicing was evident in 54% of people who were non-virally suppressed and 33% of people were virally suppressed. And all those people had a presence of the P24 protein. So overall, our research would point to evidence of that the reservoir is still active in the brain. I personally think that this data needs to be replicated in larger samples, but I think that's early evidence that it could be important. The next slide, I mean, it's a bit busy slide, but you don't have to read everything. I just want to highlight again about the persistence of the virus. This one is from Ronald Swanstone and also Serena Spudik at Yale. Basically, they used 78 people on antiretroviral who had been stable for a whole year without overt neurological symptoms. They looked at different scenarios on how the persistence in the brain could happen. And they also measured the persistence in the brain using single copy assay. And what they say, basically, they say that there could be 3 scenarios. So persistent from CD4 cell count that traffic from the periphery, from CNS resident CD4 cell count, and from CNS residual macroglia. I think what was important, and I think it confirms some of the earlier findings, they showed that the level of single copy assay that was detected was actually correlated with power and neurocognitive function. And they also showed that this level of detection was associated with the impairment of the blood-brain barrier. And I think, like we've thought a lot, is the integrity of the blood barrier is something to really take into account in the context of persistence of viral HIV in the central nervous system. The other thing that's probably going to be of interest to immunologists and who know more about that than I do was that some first evidence that infected T cell clones were shared across the CSF and the blood compartment, but also that the single cell RNA sequence of CSF identifies T cells that continue to produce HIV RNA despite antiretroviral treatment. And that the higher burden of reservoir cells in the CNS was high in the CSF, sorry, than in the blood on most people on antiretroviral treatment. The caveat of this study was a small sample size, but I think it's probably proof of concept. Next slide. So sorry, it's a busy slide as well, but I was trying to be fair to the person who presented those results. So I guess using that's the other main theme, I guess, at the conference was the issue of comorbidities. And one of the one that we're very worried about in neurofield is the cardiovascular changes, because there is so much evidence from non-HIV research that cardiovascular changes are really bad for the brain and fairly early on. And also, they're bad for people when they have it, but they're also bad as prediction of future cognitive changes. Here, people use the FDG PET to look at arterial inflammation in the carotid. And what they found basically in a relatively small sample, I mean, 47 people, but also a sample that had quite a few other risk factors for cognitive difficulties, was that there was a higher carotid inflammation in people who had been matched for cardiovascular risk between people with HIV and without HIV, and that in the people with HIV, that was associated with poorer cognitive function. I think one of the interesting findings is that they found also that race, because it's an American study, was important. So it's known that actually African-American have higher cardiovascular risk factors. So that's always an important things to consider in a diverse cohort. The next things I thought that was important is always this recurrence of data on depression. And it is a very important sort of a factor to consider in long-term neurocognitive health and mental health in people with HIV. But here, I think that what was novel in that large cohort from the CFAR network integrated clinical systems was that they were able to show that the severity of depression was longitudinal link to incidence of stroke. They also showed that it was a multifactorial effect, that substance use and other health disparity factors contributed. But I think it's I think it's an important study in itself because it's a large cohort, and it shows sort of those long-term effects on cognitive health that are difficult to, on mental health that are difficult to address chronically. The other one, so I don't expect you to read the entire slide. I've prepared a slide for them to be shared. So in a way, if people are interested, they can go and look at them. But basically, both NIH, the recognition that cardiovascular factors and diseases are becoming really a massive issue. And then there are a number of studies that basically show the effect on the brain. And there's one study, and I think that's what I guess we're a bit biased maybe, but one study that shows that some of the cardiovascular disease is associated with exhausted CD4 T cells in a subpopulation at risk for cardiovascular disease. So it's food for thoughts as well in terms of how to look at the long-term cognitive health in people with HIV. Not all people are going to have this high of cardiovascular risk. And I'm aware of the Reprieve trial. So there's also the treatment to take into account. I don't think those studies have done that. Talking about treatment, I was part of the monitoring, the data monitoring board for that trial at the top on tesamorelin. The aim was to reduce abdominal obesity and in the hope of improving cognitive function, and that was a negative trial, but the truth is that they were never able to accrue the right number of participants. So that's a negative study that we're not sure exactly what it means, but it's just to show how hard it is to conduct the study longitudinally, and it was also interrupted by COVID-19. The other one I thought was important to show was something done in Africa by Sam Nightingale, showing that people switching from efavirenz to dolutegravir, and if I'm correct, this is something that was done quite in the past year, so it's current in Africa, was not associated with any adverse effect because there's the issue that dolutegravir may be associated with some neuropsychiatric changes, so they couldn't really see that in their studies, so that was encouraging. The other one is something that's interesting. I don't know how much it will have impact beyond the neuro field, but it's again that idea that we can measure the efficacy of some antiretroviral in how they're able to treat, I guess, cognition or cognitive impairment in people with HIV. So rather than using the old way of looking at summing the different antiretroviral and how much they cross the blood-brain barrier, basically here, that new measure, it's not really new, but it says that it is new. It's just using the geometric mean. And in that study, I think it's from a group, it's for different people in the US, that the higher level of the higher T to be able to cross the blood-brain barrier was associated with a lack of detection of CSF HIV DNA and better cognitive function. So they may be useful in the future. And I just make a note of one Italian study that used non-pharmaceutical intervention about sleep quality, and that was apparently effective. The next thing is there's always some study about low middle income country, and I think they're really important because there's always some issue in implementing NeuroHIV study in this context. And so it's actually been happening for 10 years. People are doing very good studies. One in Uganda that shows no evidence of significant changes in verbal memory between people, mostly women without an HIV, and data from Leah Rubin. And I think what she shows here that's important for our context is that those people are really clinically stable. They don't have a lot of comorbidities, and their cognitive function, at least in terms of memory, is as good as people without HIV. So that's encouraging. Another study, however, a larger study shows the presence of inflammatory markers linked to cognition. So I think that's something that's starting to emerge in Africa, including the risk of cardiovascular disease. And another study, I thought it was a little bit tangential, but I thought it was important to show that when in a large clinical setting across 2 countries, where enhanced diagnostics package was introduced into routine CSF analysis, they actually were able to detect much more opportunistic infection than only using, your basic assessment. And in the introduction of the abstract, they say 30% still have opportunistic infection. So I thought that was important. And then the last part is, again, I don't expect you to read everything, but something that of interest maybe to immunologists, the fact that immune checkpoint in the central nervous system may be associated with neurocognitive impairment. My take on this is that I have never seen that before, so it would be a first finding. So that was shown in an animal and human model by those people at Indiana University, and then another group showed that it was correlated with neuroinflammation and some cognitive dysfunction. So maybe something to look at in the future. Our own research here at St. Vincent shows the evidence for a subtle, it's quite subtle chronic and slowly progressive structural and neurometabolic changes that will link partly to how people have been immunocompromised in the past, but also their current immune status and also age. And so talking about age, that I thought that study from Marie-Josée Brouillette, who I worked in Canada, should have been one of the oral. Apparently it was very well marked. But they have this study over 10 years, and I know they use very high-end statistical analysis, and they showed that in their cohort, which would be akin to a cohort here in the US, although they maybe have more people with substance use, cognition decline over 10 years in about 1 in 3 participants. And it was characterized by low immune function, higher cardiovascular risk, and liver fibrosis. So I don't think we're talking about only the effect of HIV anymore, it's other comorbidities. And the last bit that I just wanted to highlight, it was that originally during the COVID infection, I remember people saying, if people are on antiviral treatment, we don't expect people with HIV being more impacted by COVID. But there's data from the US showing that 22%, so in that particular study, 22% of people with HIV versus 19% develop some post-COVID condition, and the risk of incidence post-COVID condition among people with HIV was 19% higher than people without HIV. So I guess that's something also to take into account, considering that COVID also is bad for cardiovascular health. And that's it. So thank you for your attention. So now I'm going to be the boss on the Q&A. So if you may go to the microphone, please, so that everybody can hear you. Thank you. Yeah, I think he should be. Yeah. No, he is. Yeah, I can see him. That's going to be that question is going to be for you, Nick.
Hi, Nick. Just wondering that HCV treatment, which was associated with the higher incidence, do you have any interpretation of that data?
Did you hear that?
Is that Bayzat?
Yeah. Yes, I am.
I could recognize your voice. I mean, you're familiar with the data set, so we don't know much about these people. And when you think about who people living with HIV that are likely to access hepatitis C treatment, or PrEP users who are likely to access hepatitis C treatment, we just assume that really that intersectionality of risk factors, and then it's more likely that they acquired HIV sexually, even though that the hepatitis C treatment presumably is linked to injecting drug use. Can't really say much more than that, than a speculation around that. You know, you are aware that the HIV acquisition through injecting drug use in Australia is quite uncommon, and that most of these people taking PrEP were gay and bisexual men. Given, however, you know, with Joanne's presentation, given the low rates of reinfection with hepatitis C, I guess that would be a large underestimate of that group of people with risk factors for HIV acquisition and drug use. Thank you.
Thank you. So there's a question for me here. What are the 2 or 3 things we can recommend that people with HIV can do relatively easy to protect and improve their cognition? So I guess there's not a one-size-fits-all answer to some extent, But so I'm actually preparing a publication. It's ready for submission about answering that question with a group called the NeuroHIV Aging Advocacy Group. So which is a combination of community members all across the world, clinicians and scientists all over the world. And so we included the low middle income countries as well. So there's going to be a lot of details about what to do, okay? So, but I think your question is at the individual level, what the person can do more than the healthcare system. But so I think number one is definitely to take care of your mental health proactively. I mean, that seems a bit, something like, easy to say. And but there's really, really good evidence that, including from my own data, that when people actually are stable on their psychotropic treatment, for example, are doing the intervention, the psychosocial intervention that is helpful to them, that actually they do maintain cognitive health over the long term better than if they don't, okay? So that would be one thing. The other thing, as people are going to age, I think the same applies with cardiovascular health. So when we say this, people say, well, that's not very different from what your GP would tell you, but that's actually true. Okay, the difference, I think, what we write in that particular paper is that the context in which it has to be delivered should be a little bit different than from the general population. Anyway, so I hope I'll advertise the paper, and I hope it will answer more of the question in details. Well, then I think it will be time to close the seminar for today.